is blood. But that is not the only way. Okay, there are many three ways that cancer spreads. One is through the blood, one is through what we call the lymphatics or the lymph nodes. You've heard of lymph nodes, right? And the third is through, I'm talking about abdominal cancers and more specifically colorectal cancers, to the peritoneum. Anybody heard of the peritoneum? Anybody here heard of the peritoneum? No? So when you're learning biology and you look at the abdominal structures, one important organ is called the peritoneum. Just like how we have skin on the outside of our bodies, we all have skin. What does the skin do? There's many things, but it also protects our body against external factors and infections and so on. Similarly, we have a peritoneum inside our abdomen, which is like a lining through which the cancer can spread. So, I'm sure all of you now know that there's something called the peritoneum. And when your teacher asks you, what is the peritoneum, you know now. Okay? So, so we look at that person there in the figure. You can see that we divide the abdomen into how many, if you draw like that, how many quadrants are there? If you look at that figure of that man, how many can you see? 9? 9, right. So 9 plus if you look at the other figure here, there's 4 more quadrants. So there's 9 plus 4, that's 13 quadrants. So we calculate how much cancer spread on each of these quadrants. If it is, depending on the size of the cancer spread, we calculate a PCI. The maximum score is 3 per quadrant. So what is the maximum score that can happen if it is 3 per quadrant and there are 13 quadrants? Use your mathematics skills. The maximum score is 3 per quadrant and there are 13 quadrants. So what is the maximum score? 39? 3 times 13? So that's why you have to know your math tables. 3 times, immediately you should know 39. Okay? So the 39 is the maximum score. So we calculated on that. So now get ready to watch a small video. This is an old video about 12 years ago. I did this survey about 12 years ago. And are you okay to watch this? Okay. So we are opening the abdomen. This is not robotic surgery. This is what we were talking about. This is a normal surgery. Okay, so we are going inside the abdominal cavity, but we're not really inside the abdominal cavity yet. As soon as we are inside the abdominal cavity, I will tell you. Look at that. Have you lost your appetite? You can see that intestine, you can see those small spots. That's all cancer. That's all cancer, okay? So we score the cancer totally and we have to remove each and everything that we see. I warned you, don't tell me I didn't warn you, okay? So you can see that we are removing every spot of cancer that is there in the abdomen. And this particular cancer did not start from the colon or rectum, it started from the appendix. This is actually a cancer of the appendix that spread, believe it or not. So if it is too much, we remove that part of the intestine and we take it away. And then the part that is remaining, we join it back together. This is the liver. So we're using a special machine called a CUSA machine, which is an ultrasonic machine to remove the capsule of the liver. And this is the diaphragm. The diaphragm is the division between the chest and abdomen, right? And now we're joining the intestine or bowel back together again. It can be done through stapling devices or through hands-on techniques. Right? So you can see after the surgery, it's very clean. There's no more cancer left behind. So after we remove all of the cancer, we then put chemotherapy into the abdomen. Right? This is human surgery, real surgery, okay? So we put in inflow catheters and outflow catheters with temperature probes in them, and we circulate chemotherapy, which is heated at 43 degrees Celsius for 90 minutes, 90 minutes, through a special machine. And this kills the microscopic cells. This kills the cells we cannot see with our naked eye through direct contacts. It can penetrate up to 6 millimeters. So this is more later one, but I won't show you the gory details. So this is what this see all the cancers come out. This is another patient. Many times we have to remove the uterus, the ovaries, and so on. And then this is the latest machine that we use called the RAND machine, which is a HIPEC. This is called HIPEC, hyperthermic intraperitoneal chemotherapy, HIPEC. So we are not only removing the cancer, but we are instilling chemotherapy into the abdominal cavity to kill the tumor cells through direct contact, not through the blood, right? So for that we have to be sure that the cancer is not spreading through the blood, but through the peritoneum, right? So this is the machine that we use. We can also do this laparoscopically, like I mentioned, not robotically, but laparoscopically, and also robotically. So laparoscopic is we're putting a camera inside, and we're doing. You can see these white spots. Those are the cancer cells, cancer deposits. And so we can remove all of this laparoscopically without giving incisions. So you can see us removing that is the peritoneum. You can see where the spots are, that thin layer. Can you see that coming out now? That is the peritoneum. That is the peritoneal layer that we are removing. Okay? So that is a bit about laparoscopic surgery. And sometimes, unfortunately, the cancer has spread too much, and we have given chemotherapy, we've done everything, but it's not really, we don't think we can cure the patient, okay? And again, this is a HIPEC patient. So different machines that we have used, I'll just go past this. So there's another procedure called PIPAC, which is pressurized intraperitoneal aerosol chemotherapy. So this is for patients who have a lot of water collecting inside the abdominal cavity called ascites because of cancer. And we have given chemotherapy, we have done so many things, but nothing is working. And so we do a laparoscopic procedure called PIPAC. It's very different than the HIPEC that I just showed you. And I'll just show you a video of a PIPAC procedure. We put two trocars, one 12 millimeters and one 5 millimeters inside the abdominal cavity as shown in this figure. And we use a special injector to convert the liquid chemotherapy into a gaseous form, or aerosol, like your deodorant spray. So it's actually liquid, but when it comes out, it's like a gas, right? So we put a 5 millimeter trocar, which is very small. 5 millimeters is like half a centimeter, and one 12 millimeters, which is a little bit more than a centimeter. And there's a balloon at the end of it, which we insufflate, which we can fill up, because we don't want the chemotherapy which is circulating in the abdomen to come out by mistake. And what happens is the doctors and the nurses and the staff are inhaling the fumes of that chemotherapy, and it's a biohazard. It's harmful to us, right? So in this, when we're giving the chemotherapy, even the anesthetist has to go out of the operation theater during that time and put the monitors. So this is called a Capno pen. This is a special pen which we import from Germany, which converts the liquid chemotherapy into an aerosolized form or a gaseous form. So this is what it looks like inside the abdomen. And this is the injector I was mentioning, which we set at a particular rate, which then pushes this chemotherapy. Can you see the gas inside? Can you see the fumes? You can see the fumes. It's spraying everything like a smoke. Okay, so this is, and we all go outside the theater because we don't want to inhale this by mistake. So we all go outside, even the anesthetists go outside. Once we're done with that, we come back inside. We evacuate all of these fumes through a smoke evacuation system, and then close up the patient. So this was Professor Mark Raymond who invented this procedure in Germany, and we published various articles on this procedure and how it helps. There are a lot of future directions. But one more thing I want to tell you about is these are the liver. If the cancer spreads to the liver, we can remove that part of the liver. If we're sure that we can remove the entire cancer by removing that part of the liver. But I want you the last one procedure which is not being done anywhere outside the US, maybe, except in our center, is called a hepatic artery infusion pump placement. So we understand that the liver has two blood supplies. Anybody knows the blood supply of the liver? You learned in biology or didn't learn in biology? Some senior people here? So there are two blood vessels that go to the liver. One is called the portal vein and one is called the hepatic artery. And the hepatic artery is the one that supplies the tumors. If a tumor forms in the liver, otherwise 80% of the blood supply of the liver is supplied by the portal vein, not the hepatic artery, right? So we place this catheter inside. Another video I'm showing you. These are the metastasis. That means the cancer spread in the liver. Can you see those white spots? Those are the metastases. You can see a PET scan. This is a cancer scan. The yellow showing the cancer in the liver. The yellow and white parts, right? So we again go into the liver and we find the hepatic artery, which is supplying the liver. This is the gallbladder being removed. So we have to remove the gallbladder because we don't want the chemotherapy to go to the gallbladder by mistake because it has similar blood supply. So we find the hepatic artery. Then this is a special pump that can be programmed through Bluetooth. So the rate of this is inserted into the patient's anterior abdominal wall. That means below the skin of the abdomen. We make a pocket and we place this catheter there and tunnel this catheter through the abdominal wall and insert the tip into the hepatic artery. And then we can put chemotherapy into this pump and program it to run for, let's say, 2 weeks. So the patient goes home and the chemotherapy in very high doses is going to the liver and killing the cancer cells in the liver, right? So you can see we have to make sure the blood is flowing well, so blood will be seen. So if you don't like blood, surgery is not for you. Okay, surgery is full of blood, and you get used to it. So in our first year of medical college, many of the students fainted when they saw all this, but you get used to it when it starts. So we program this pump through a Bluetooth device, so we can set the rate of flow, and then we can check. And the patient comes to daycare every 2 weeks, and we reinsert the chemotherapy, and that goes on. So this is not the normal chemotherapy. Don't think that this is how chemotherapy is given. These are special ways that we are very modern ways that we are helping patients improve outcomes through techniques like this. So I hope you all okay, not feeling nauseous. So little advanced topic. I hope it wasn't very gruesome for you. Yeah. And I don't know if anybody has any questions about this because it's a little difficult to digest. But this is the work that I do, so that I just thought I'd show you. This is what I specialize in. And because of these systems, so in the past, if you were a stage 4 cancer patient, everybody would say that there's no chance of you being cured, right? Stage 4 means the last stage, only 4 stages of cancer. So if you're stage 1, yeah, you have a good chance, maybe 90% chance of cure. 2, it goes down below 80 or 75%. 3, you say you have 50-50. You might be cured, might not be cured. And stage 4, you have 0% chance. But now, especially in colorectal cancers, because of these treatment options, we are seeing patients being cured. So we have patients who are living for 10 years and more than that in metastatic, that means stage 4 colorectal cancers. In early stages, yes, the cure rates are much higher, above 90%. So cancer is no longer a death sentence. It used to be in the past. But now, there's only very few techniques I've showed you. There are so many more techniques that we can spend all day doing it, boring you about it. But these are few techniques that we specialize in that is helping our patients live a more meaningful life and with a better quality of life, more importantly, more than survival. So I think I won't go on about this. If anybody has any questions related to anything about surgery, cancer, robotics, or AI, we can quickly answer those questions. Anybody wants to become a surgeon? Yes, one guy. Good. Good. So it's an excellent field. It's very satisfying. So the difference between surgeons and physicians who prescribe medicines, you imagine a doctor as someone who writes medicines to make you well. So it's the medicines that are acting. I just decide what medicines. But as a surgeon, you get the satisfaction of actually doing something with your hands to actually heal patients. Obviously, you're just a medium. You're not doing anything. It's always God that does it. But you feel honored to be an instrument of God to help patients heal. Okay, it's not like you don't have complications and all those things. It's very stressful, but you can. It's a very satisfying career choice, and I'm very happy with my decision to become a surgeon. Okay, no questions.
So good afternoon. My name is Casey Velasco from Grade 12 Beryl, and my friends and I were wondering if does robotic surgery cost more than a regular surgery, and why?
Okay, you guys are asking some very good questions. Um, yes, the answer to your question is yes. It does cost. So that is the limiting factor right now. So many patients do come up to us so the insurance systems like here are not very robust even in my country. So many patients have to pay by themselves, and everybody cannot afford to get robotic surgery. So the reason robotic surgery costs more than normal surgery is that each of these instruments that you saw the instruments coming in. Each of these instruments can be used only a limited amount of time, and each time it costs a certain amount. So let's say it costs, um, I would say around 150,000 pesos more. That's 2 lakh rupees more than the normal surgery, right? So that is quite a hefty amount. So many times patients want robotic surgery, but when they hear the cost, then they're like, no, this go for the normal surgery. But this cost is much less now than it used to be in the past. It used to be much more, and with newer systems that I showed you, it can come down to less than 100,000 pesos. I'm sure soon it will be like about 50,000, which is something for major surgeries, which is worth it. I think so. I think within a few years it will be that much. And the reason for that is they're disposable instruments. They're consumables, they get consumed, and each time they cost. So each time you insert that in the patient, each arm, so there are 4 arms, so each arm costs like, in our currency, about 20,000 rupees. So times 4, and then there's a charge for the robot itself. So that's what the hospital charges.
Thank you. Some more questions? Dr. Vinay, how about when it comes to precision? Which is more precise, robotics or the by hand?
Yes. So one of the taglines used for robotic surgery is precision surgery. It's very precise. Okay, but the thing is, it does not have the sensation of touch, or we call it tactile sensation, and there's no haptic feedback. So basically, you have to depend solely on visual signals. So you can have excellent resolution, 3D vision, magnification, all of that, but I cannot touch and feel the consistency of a tissue. I cannot do that in robotic surgery. So therefore, for like the surgeries I showed you just now, the big ones, we can't think of doing that robotically because I have to feel with my fingers the cell, how hard it is, how soft it is, what is the texture, all those things which I cannot do robotically. Sometimes the tissue might look normal, but it might be pathological or it might be diseased. So to recognize that, we have to actually use that. So the answer to your question is, for most operations, robotic surgery is more precise because you can, there are no tremors. So we can, as we go older, your hand starts shaking. You can be a little less precise. That all those tremors are nullified in robotic surgery. There's zero tremors when it's actually acting on the patient, and you have magnified vision. So I cannot go like this and look down inside the patient, but a robot, I can go with the camera right down, right next to it here, and I can see each nerve at like at least 10 times magnification than with the naked eye. So it would be, in a nutshell, I would say robotic systems are more precise for most surgical procedures, not all of them. Yeah. You have a question?
Yes. Would you like to go there?
So, good afternoon po. I'm Paul Gonzalez from Grade 12 Burial. And I have a question regarding the use of artificial intelligence and robotic surgery in cancer treatment. Does the robotic or the AI is it able to identify suspicious tissues and metastases during the operation as it happens?
The questions are getting better. Okay, so wouldn't that be wonderful, right? If I could localize, especially the hidden cancer cells, which I cannot see with a naked eye. So we have certain systems. That is why the use of VR, virtual reality, and all those things are coming in. But real-time localization of lesions are being done through what is called infrared technology, near infrared lighting. Okay, near infrared lighting, and ICG, which is what I showed you, the indocyanine green. So if you inject that, or for tumor localization, we can inject certain dyes, certain contrast medium that can go and they show uptake in those, let's say, lymph node glands, on those what we call fluorescence guided surgery. So you can use fluorescence, change the wavelength of light, and when you shine that light, the normal light we use is called white light, right? So that's using all the colors of the spectrum. But if you use different spectrums of light, you can localize the cancer cells show uptake of that light. So it comes out as a green color or some other color, which would be otherwise invisible to the naked eye. So that is already happening, but that is being refined in a more specific way. So there are various ways that we localize, and we also use intraoperative ultrasound. During the operation, we can use a special robotic ultrasound probe on the liver, other organs, which have high frequency capabilities, so we can identify very small lesions, like a millimeter or less than that. Otherwise, for CT scans or MRI scans, we miss many small lesions, like you rightly pointed out. Right? So that is something that's a work in progress, and it's worth pursuing that. So when you become a doctor, I think that's what you should do. Yeah?
Okay, thank you. Some more? Yes, please. Okay, so we have two. Yes, and then you kindly follow.
Hello, my name is Monray Valdez. I am grade 12 from Diamond. My question is there situations where a patient refuses to get operated by robotics? So what is the best action in that situation?
Okay, again, practical question. Yes, many times, like I mentioned to you, so if you're saying they refuse it because they can't afford it, then we try to help them financially in some way. But if they don't want it for some other reasons, let's say all surgeries can have complications. So somebody they knew, and someone that person knew, and this neighbors, dogs, uncles, somebody had an robotic surgery which got complicated, and said, no, robotic surgery is very bad. I don't want robotic surgery. Is that the situation you're talking about? Then yes, I have the answer for you. So there's a lot of hype and media behind everything that we're doing. Like ChatGPT, we all know chatbots. We use chatbots all the time for virtual assistants. So we know all of that. Similarly, robotic surgery. All of you have heard of robotic surgery before you came here, right? You knew there was something called robotic surgery. You might not have known exactly what it is, but you knew about it. So sometimes, especially people coming to us from the villages and other parts, they have this concept that the best way to do an operation is manually through the hands. They do not want even laparoscopic surgery or robotic surgery. In which case, so we cannot say that normal surgery is inferior to robotic surgery. You get my point? It's not, well, it's just that the recovery and the complication rate might be slightly higher, the bleeding might be slightly more, the pain might be slightly more, but it does not mean the end result is worse. So all of the studies that have shown robotic surgery is superior, is so-called better than open surgery, is for something like pain is less, bleeding is less, patient goes home faster. But for example, cancer surgery, I cannot tell you that if you get a robotic surgery, your cancer will not come back, and if you get an open surgery, your cancer will come back. The chances of cancer recurrence are the same. Not better with robotic surgery, not better with laparoscopic surgery. So the what we call long-term outcomes, like what is going to happen to the patient 5 years from now, 10 years from now, they are virtually the same, be it robotic surgery or be it open surgery, except the chance of hernia, hernia formation. So that because of the incision, and let's say you do your activities, increased intra-abdominal pressure, then you can get a bulge coming out from your abdomen. That's called a hernia. So because of the open surgery, the chance of hernia formation is more. Then you might need another operation, putting a mesh and solving the hernia. So that is the downside of an open operation. That doesn't happen in robotic surgery because there are no incisions to form hernia. Otherwise, I think it's justified. So if the patient does not want robotic surgery, there's no need to force a patient to get robotic surgery. Some patients refuse to get surgery. Now, if you go one step behind that, you can see a curable cancer, first stage cancer. The patient says, no, I don't want any surgery. I'm going to go to my guru and pray on the mountain and take natural remedies. That happens to us all the time. And then, there's some people who claim that it works. But what I have seen is that they come back, maybe to somebody else or to me, in stage 4 disease now, incurable disease. And at this time, there is no point in doing an operation. It's not going to help them. Right? So, there are many patients who refuse surgery, saying, I'm going to take naturopathic treatment or homeopathic treatment, and so on. So, the patient has a right to choose the treatment, but it's our job to educate them, counsel them, and guide them in the right path. The final decision is obviously with the patient, not with us.
Thank you very much. Yes, we have here, and then followed by one at the back, then here. So we have, and this is the, okay, so 1, 2, 3, 4. Okay? Dr. Vinay, is that still okay? All right, let's start, please.
Hello. Hello, my name is Lance Carrillo Riazo. I am from grade 12 Diamond. So my question is there an age limit when operating in robotic surgery? So when you're doing robotic surgery, can you operate to a baby or a child, or is there like a, what is this called? Like a restriction, yes, to when operating with robotic surgery. So that's my question. Thank you.
Okay, great. So when you said age limit, the first question I was going to ask you, are you talking about the surgeon's age or the patient's age? Okay, but yeah, the patient's age, then patient's age, are you talking about the younger side or the older side? Yes, there is an age limit, but it's mainly on the elder side. Like if you, and it's not only just the age, age is just a number, right? Age is a number. You might be a 60-year-old, but you might be like a 90-year-old physically. You can't even walk. You might be unfit. You cannot tolerate anesthesia. You might be having blood pressure, like high blood pressure, diabetes, brain stroke, and you might be 60 years old, or you might be 90 years old and you might be fit. So age per se is not a very strict number for the higher cutoff, but let's say for pediatrics, like for child, you're talking about children, right? You're talking about children age restriction for the young. How young can you be to have robotic surgery? Is that the question? Yeah. So people have done robotic surgery in the womb also, like before the baby is born. You can literally take the baby out of the uterus, do the robotic surgery, and put the baby back inside before the baby is born. I'm not joking, you can look it up. Okay, it's actually being done, especially for diseases of the kidney, in which there's a blockage of the kidney. When you do an ultrasound of the mother, when you're doing an ultrasound of the mother, you can diagnose these diseases before the baby is born. You can diagnose that there's like a hydronephrosis or urethral atresia. These are diseases that can be diagnosed before the baby is born. So we can now actually, not through the mother, but we can actually get the baby out, do a surgery while the baby is still attached to the mother, and put the baby back in. It's not science fiction. It's actually happening, and that can be done robotically. Now the instruments of robotics, like I said, are usually 8 millimeters in diameter. So 8 millimeters for you and me is fine, but 8 millimeters for a baby, a newborn baby, is too large. It's too large. It's not worth doing robotic surgery. So there are certain robots that are designed for pediatric patients, but they're more expensive, right? So because the instruments have to be really fine and go through, let's say 5 or less than 5 millimeter diameter of caliber. So it is pediatric robotic surgery is there, but it's a very specialized branch, and it requires specialized instruments to do that. But it is possible. There's no real cutoff for robotic surgery, age-wise.
Good afternoon, doctor. I'm a college student from the business administration. I was curious about, since it's being said that AI is the future of medicine, I would like to ask, is there a possibility or has there been research or current cases that the percentage of cancer recurrence using AI surgery is lower compared to other treatments?
Thank you. There is absolutely no evidence till date, no evidence, no level 1 evidence that AI improves patient outcomes till 2025. Not even one article that substantiates the fact through a randomized controlled trial that artificial intelligence incorporated into healthcare improves patient outcomes. It might improve many other things. Like you said, cancer recurrence, does it show that these technologies decrease the rate? No, there's no study yet. There are ongoing studies, yes. And since you're in business administration, most hospitals are run by MBAs and business administrators now. Most of our CEOs want AI. So they say, what do CEOs want? We want AI. When do we, what do you want AI for? We don't know. When do you want it now? So that's how it is. Like everybody wants to do AI, a lot of hype. We want it now, we want to incorporate AI now, but nobody knows what it's about. You just say, oh, ChatGPT, oh yeah, I use AI, I use ChatGPT. So AI is much, much more than just ChatGPT and these other like translational models and large language models. There's very minute part of the entire universe of artificial intelligence. But Yes, there's absolutely no evidence to coming to your questions. There's ongoing research, yes, but to design these studies, we need people like you and me and people sitting here forming teams, coming up with this evidence. They don't happen automatically, and people, you won't get many grants for it. So it has to be done at a very parsimonious level, frugal level. You can't have too many grants for this, because many times it will be negative. Most of the time the outcome is negative, that yes, it does not improve outcomes. And who's going to fund that? Nobody wants a negative outcome. Everybody wants a positive outcome of the study, right? So it's a work in progress, but there will be evidence in the near future that I'm very sure about, because I know of multiple studies that are ongoing in various countries and multi-centric studies, so the world is very small now. So being here, being in the Philippines, being in the US, it's very small. You can easily collaborate across the world easily to formulate studies and carry them out. It's not a challenge anymore.
Thank you. Another question? Yes, please. We are so blessed with very active students, especially our academy. I hope you are inspired. Okay, yes, please go ahead.
So, hello, my name is Lana de la Cruz, and I'm from grade 12 Diamond. So, my question is, when is robotic surgery considered the best or most appropriate option for a patient? How do doctors decide if a patient should undergo robotic surgery?
Okay. Thank you for the question. So it sounds like a very simple question, but it's a very complex question that you asked. So when is robotic surgery, let's say, the gold standard? When is robotic surgery the best way to do an operation? So as we're talking science here, we're all pupils of science. So till we get evidence through trials that robotic surgery is superior to other types of surgeries, we cannot absolutely recommend robotic surgery, right? But any surgery that can be done laparoscopically, for example, in our grandfather's time, to remove a gallbladder, there was no laparoscopy. We had to make a big cut and the gallbladder was taken out. That was the gold standard. When laparoscopy came in, everybody was, this is very bad, this technology is bad, there are a lot of complications. But now, if you give a cut for removing the gallbladder, it's crazy, primitive. It's always done laparoscopically. Very rarely do we have to give an incision for removing a gallbladder now, right? Similarly, the next step now is robotic surgery. Even for removing the gallbladder, robotic cholecystectomies are being done regularly. But I would say specifically robotic surgery helps those people, obese people who are really fat, really overweight, who are, let's say, specifically who have, let's say, cancer, which is very hard to detect, rectal cancer. You cannot see, the pelvis, especially in males, is very narrow. You don't have space. So to get negative margins, so we want to make sure that there's no tumor where we're cutting. So for low rectal cancers, when we want to preserve the rectal passage, we don't want to remove the sphincter to control the passage of stool. So for those patients, I would strongly recommend robotic surgery because it is showing superior outcomes for the continence. That means for control of the passage of stool and urine. So for rectal cancer, for preserving the kidney, like for partial nephrectomies, when you have a tumor on the kidney, you can remove only the tumor without removing the kidney. So for that, robotic surgery is superior to other surgeries. And for bariatric surgery, you know what bariatric surgery is? Bariatric surgery. It's the fastest growing field of surgery now. It's called bariatric surgery or weight loss surgery. You haven't seen one big fat guy and suddenly the next month he's one skinny guy. And you think, oh, is he taking Ozempic or is he taking Monjaro? But actually he had a surgery to remove most of his stomach. So that's called bariatric surgery or a bypass surgery. So because obesity is a very big problem now, even in younger people. So for those surgeries, we are usually doing it robotically. We don't want to give an incision on a really overweight person and create more complications. So in these type of surgeries, I think robotic surgery is really showing promise in terms of improving the recovery of these patients. So bariatric surgery, certain cancer surgeries, certain complex hernia surgeries, especially in complex surgeries, robotic surgery is definitely a better way to go. Easier on the surgeon from my side as well as for the patient.
Thank you, Dr. Vinay. Another question over here, please.
Good afternoon. My name is Tam Calatrava from grade 12 Diamond. And my question is, can robotic surgery be used in all surgical procedures?
Okay, great. So it's definitely not a one size fits all. You cannot do robotic surgery for all procedures. You can do them for most procedures, but not all. Like for example, if you watch the first video I showed you, did you remember that with all the cancer everywhere? How are you going to do that robotically? I mean, I don't know because, or let's say there's a large tumor like this. I've removed a 21 kilogram tumor. 21. I don't know what that patient was doing at home. They couldn't even lie on the side because if it 21 kilos is compressing your blood supply to the heart, they have to sleep on the side. So the weight of the tumor does not, press the arteries. So then the entire, body loses blood supply. So those type of large tumors, intestinal adhesions, uh, patient not fit for pneumoperitoneum. For robotic surgery, we have to insufflate carbon dioxide in the abdomen. Carbon dioxide. So when you push air in the abdomen, it pushes against the heart and lungs. And so if the patient is already cardiac, this compromise, if the heart function is not good or the lung function is not good, you cannot add more pressure to that. So at that point, that's a contraindication. That means we say you're not a candidate for robotic surgery. You have to undergo open surgery, or you had multiple surgeries in the past. Multiple surgeries, you cannot enter because everything is stuck to each other. All the organs are stuck to each other. When you've operated multiple times, we would not want to do robotic surgery in those situations. And for large tumors, for a complex situation in which you want to feel, when you want to have tactile sensation, you would not. But generally, for most procedures, robotic surgery is possible and is recommended. But sometimes we just recommend it blindly, but that's not the right way. You have to be. Not all surgeries should be done robotically, even today.
All right. Is there another question? We still have time for maybe one or two questions before. Ah, yes, over here, please. Thank you.
I'm Jade Sivida Valena. I'm from grade 12 Diamond. My question is, how long does it take for a surgeon to be trained in robotic surgery?
Okay. Good. So somebody's interested in becoming a surgeon. Good. So it varies from country to country in how your curriculum is, how your education system is. What I can tell you is that first you have to do your undergraduate, you have to do your medicine, right? In we call it the MBBS. What do you call it here? MD. You first do your MD, so you become a doctor first, right? Able to treat all diseases, general practitioner. Then after that you do your residency in general surgery, in which you learn all types of surgeries. How to do open surgery, how to do laparoscopic surgery, how to do neurosurgery, cardiac surgery, all surgeries, pediatric surgery. You have to understand the basic of everything. Then you might want to specialize in a certain type of surgery, like cancer surgery or let's say weight loss surgery, whatever it might be. So all these years are adding up, right? All these years are adding up. And then once you are a surgeon, So the answer to your question is, once you're already a trained surgeon, it might take you not even a month or less than a month to be a robotic surgeon. So once you know how to operate, uh, it's like saying if you know how to, I know how to bicycle, I know how to ride a bicycle. How long am I going to take to ride a motorcycle? I think in a month, if you practice every day, in a month you'll be good to ride a motorcycle. So similarly, if you know how to operate, you know the planes, you know the anatomy, you know the basic surgical principles. Learning how to maneuver the robot is not a very difficult thing. So you have to learn how to use both your hands and both your feet, but it's pretty simple. Well, if you're a good surgeon, you will be a good robotic surgeon. If you're a bad surgeon, you will be a bad robotic surgeon. Your robot doesn't make you a good surgeon if you're a bad surgeon. So that's how it is.
All right. So you want to go for a training later once you become a doctor. Thank you. Okay. Is there some more? Are there some more questions? There's someone who raised hand earlier. No more? Comment? Okay, so Dr. Vinay, maybe
Thank you all so much. Thank you. It was a pleasure.
you may want to say some
some
maybe
words?
concluding remarks just to close
Yes.
your.
So I really want to thank all of you for staying to the end. It must have been a bit boring in some parts for those of you who are not interested in surgery and robotics, but I hope it helped some of you to understand what surgery is about, what robotics is about, and I hope it inspires some of you to become robotic surgeons or surgeons or cancer specialists or whatever specialist it might be. And I hope you have some things to take home after this session today. And I want to thank the AUP and the dignitaries here for having me here today. Thank you so very much, and hope to see you sometime in the future again.
May I request, so we would like to thank the Lord for this opportunity we had with Dr. Vinay Samuel Gaikwad. I hope you were inspired. Somehow, seeds have been planted in your heart, especially our grade 12, as you are still praying and trying to seek God's will for you as what you will take in your university life. Remember to do what God wants you to do. So at this point, we will be awarding our certificate. Photo muna tayo. Okay. So, photo with everybody there. Okay. And then also, okay, we'll first have, because the president has to go, let's have a group photo. So maybe if you could compress to the middle. That's okay? Okay. With Dr. Vinay, our speaker. Don't forget our speaker. Okay. Offer them. Pastor, will you join us? All right. And very quick, Dr. Arceli will just be awarding our certificate to Dr. Vinay. Please come and... Ma'am, will not have a picture anymore. Ma'am? Later na lang. Okay. So, Dr. Vinay, please. May I request the Dean of the College of Science and Engineering and Technology, Dr. Balila, to come and join me in the awarding of our Certificate of Appreciation. and other associates who are around here. Okay. So AUP, Certificate of Appreciation is hereby presented to Dr. Vinay Gaikwad for serving as our resource speaker during the special colloquium today, November 17, 2025, Artificial Intelligence in Robotic Surgery, signed by the VPA, Dr. Grazel Saban, President, Dr. Arcelia Rosario. Let's give Dr. Vinay a round of applause. We also have here a box of the best baked products in the world from AUP Health Foods Factory. I hope you will enjoy.
Thank you. Thank you so much.
Yes. And there's one more. We have also here our AUP hoodie jacket for you. Okay. So maybe Dr. Eddie will hold the box so you can just hold, and then just hold the certificates. Can we invite the parents to join in the picture taking before we stand and pray? So, right. Thank you so much, Dr. Vinay, once again. Okay, so once again, before we start, I'd like to thank everyone for coming to our academy, our CSET students, engineering, and other faculty and staff who are here. Thank you to Sir Win Pasamba, who recorded the session. Thank you, Sir Win, for your service. And shall we now all stand for the closing prayer to be offered by Dr. Edwin Balila, our CSET Dean.
Let's bow our heads for prayer. Our most gracious and loving Heavenly Father, we thank you for this wonderful opportunity to learn and to be inspired this afternoon. We are grateful for Dr. Vinay Gaikwad for sharing with us a glimpse of how artificial intelligence is shaping the future of surgery and healthcare. Thank you for opening our minds to new possibilities and helping us appreciate how science, technology, and engineering can be used to save and improve lives. Lord, in our presence, we have the academy and the undergraduate students. They still have at the beginning of their academic journey. But moments like this reminds us that learning has no limits and that you have gifted us with curiosity, intelligence, and purpose. May the insight we gain today sparks in us a desire to grow, to explore, and to use knowledge responsibly. We ask that you bless every student here, guide us as we continue our studies, and help us discover the path you have prepared for us. We pray also for Dr. Vinay Samuel Gaikwad. Continue to bless his work, grant him wisdom, and use him to inspire many more young people. Thank you, loving Father, for hearing and answering our prayers. In Jesus' name we pray. Amen.
Thank you, everyone. God bless you, and see you around.